Hello. Oh. Hello, everyone. We're going to get started, so please take your seat. Thank you, thank you, thank you. All right. Sean, Matey, we're going to get started. Do you want to say hi?
Hi, everyone. Hi. Can you hear me okay? Thank you, everyone, for joining us today on the last day of the conference. I know you're all tired, and we're here in the corner of the conference center, but excited to have you all here today for our session on developing new tools with product development partnerships, IAVI, TB Alliance, and Find. We have one more speaker on the way who'll join us in a few moments. And I'm really happy to welcome Robin Waite and Mike Frick, who I'm sure many of you are very familiar with, to moderate today's panel discussion. So I hope you enjoy today's talk.
Thanks, Sean. All right. Hello, everyone. So today we're going to hear from 3 different product development partners who are primary drivers of innovation in the fight against tuberculosis. And for those of you who don't know what PDPs are, I'm going to give you a little bit of a briefing right now. Okay, so product development partnerships, they're relatively new models still. They started coming into existence in the late 1990s and early 2000s in response to the fact that traditional for-profit pharmaceutical companies and partners weren't investing in new tools for the fight against TB and other neglected diseases. So for-profit pharma essentially didn't see a market incentive in investing in these spaces. So really, the PDPs here today are critical drivers to this innovation right now. PDPs are not for profits, and they're primarily funded by nation states, so like the US, Australia, Canada, amongst others, and philanthropic donors like the Bill and Melinda Gates Foundation. Okay, I'm going to pass it over to my co-chair Mike, who's going to frame this session in the context of the high-level meeting that we just had and the commitments to R&D that PDPs are supporting to deliver on.
Okay, hi everybody, good morning. Thank you for coming to our beautiful hallway that we call Community Connect. Foyer Blue, yes, we love it here. So in September, we had a high-level meeting on TB. Many of you were there. I'm looking at the audience. I think I saw a lot of you in New York. Member states made new commitments, and we wanted to make sure that those included commitments to research and development and innovation. And, you know, we can look at the political declaration that came out of the high-level meeting as having positives and negatives, but my feeling, you know, we're 6 weeks out from the meeting, something like that, time flies, is that we actually did pretty well when it came to R&D in the political declaration. We have a funding target, $5 billion. It's not exactly as we would have written it, because we need $5 billion a year for TB research, and it was written as $5 billion a year by 2027. So there was a little bit of watering down that happened there. But we had very clear statements that we need new drugs, new vaccines, new diagnostics, and we need to make them available in an equitable way through local manufacturing, through innovative delivery, through the involvement of communities. And we also have a really big focus on making sure that the research we're doing is fair and equitable, learning lessons from COVID-19, and that we have access to medicines. And I think that when you look at the R&D pieces of the declaration we have now compared to the one we had in 2018, it's fuller. They're more fleshed out. We've evolved the narrative. It's a stronger declaration on research than the one we had, and we can be really proud of that. So what we want to talk about today is the role of our PDPs in meeting the high-level meeting R&D commitments. And then we'll hear also from Nandita when she arrives on the role of advocacy, TB survivors, in connecting research to the people who should benefit from it. So I'll hand things back over to Robin to introduce our speakers.
All right, so we're going to hear from each of our PDP partners in the room today. We're going to start first with Makashmi from Find. What we'd like to hear from you is introduce yourself, tell us a little bit about Find, the work that you're doing now, the challenges and the opportunities for R&D, and what you're going to be doing to deliver on the promise post-HLM.
Hello, everyone. Thank you, Robin. Before I do all of that you just asked me to do, we are fresh. We have just had our coffee, so I want to start with a question. How many of you this morning actually woke up and wrote a letter on a piece of paper and posted it to somebody? Anybody? If you woke up this morning, wrote a letter on a piece of paper and posted it? Okay, great. Anybody who woke up this morning, wrote a message, WhatsApp, Instagram, Twitter, wrote an email, or made up a call and actually had a reply back? Anybody? Awesome. This is what we want to talk about, because this is innovation. This is something new in technology. We used to write letters before. Even there was an era where there were birds used to send messages. But we are now in that era where we can, just by a click of a button, we can actually send a message, we can have a communication and get a reply back. And that is the dream, where if I go back into the community and ask people who have been diagnosed with TB, I get the same response. How many of you were diagnosed with a smear microscopy? I shouldn't be seeing any hands raised there, versus how many of you actually had a rapid diagnostic test done when you had signs and symptoms of TB. So that is the dream that Find, as a PDB developer, has to get innovations in the field of TB in terms of diagnostics, where we do not have to rely for a test to be done and get a result back, go back home, maybe in a week, in 2 weeks, come back and get a result, you have TB or you don't have TB, and keep suffering for the next 1 week or 2 weeks. And that is what we do to get innovations, to get equitable access, whether it is in terms of making tests, co-developing tests, evaluating them, that can be used in the community, that is easy to use, and then we can get the results out faster for patients to be put on treatment. Good morning. My name is Mikashmi. I work at Find, as I just mentioned. My role at Find is to figure out what are the new diagnostics. We work in that field. We work with the manufacturers to see what is the need, where do we need to have that innovation so that we don't write letters, we don't wait for longer diagnostics, and then evaluate them independently, and can they be used for public health good. So that's the role of Find. And how we are working on it is, just as I mentioned, to reduce the diagnostic gap, because for TB, when a patient goes into a clinic, the first step is to diagnose the person who's actually there. Hi, Nandita, you can join us. When the person goes into a clinic to actually see if you have signs and symptoms, will the person actually be confirmed with TB? And in the care cascade of the condition, there are only 60% of the people who can actually be diagnosed with TB. So we are missing that 40%. That's the biggest gap, and that is the biggest gap in the care cascade. So to reduce that gap, we are working on innovative tools to reach the community faster, to get the results back faster, and then being put on treatment. And this is a statistics just mentioning from the Global TB Report of 2023. Only 60% of the people actually get diagnosed with TB. Of the people who should actually be treated, 85% of them are treated. So I think we not to say that we are perfect in the field of treatment, but at least we are doing better in treating people. We're just not doing better in seeking them. So that's the promise, and that's the vision that Find has in getting there and reducing the gap.
Thank you, Makashmi. Appreciate that. Over to Anu from TB Alliance.
Hi, good morning, everyone, and thank you for the opportunity to speak this morning. My name is Anu Mahalinga Shetty. I work at TB Alliance in External Affairs, actually, primarily in resource mobilization, securing resources, and donor engagement. As Robin has mentioned, TB Alliance is a nonprofit. We are a PDP working on the discovery and development of improved TB drugs and delivering them to patients all over the world that desperately need them. Um, TB Alliance developed and registered pritominid in BPAL-M a few years ago. And has been transformative, really, in treating drug-resistant TB, as we know. It is now available in over 150 countries. And just during this week, we've been able to publish and share really exciting results of some of our work in countries in Asia. So for example, in Pakistan, the results of our implementation and operational research has resulted in the updated national guidelines. Similar results in key countries like the Philippines, Indonesia, Myanmar, points to an even faster uptake of the regimen in the region and elsewhere as well. I want to emphasize that a critical part of this success has really been our approach in ensuring that community and key stakeholders are involved in every aspect of our work, from discovery, development, and delivery. I think a common theme that I've heard in all the sessions that I've attended this week is that without the involvement of community and those impacted by TB and patients, none of our work is really, there's a point to it, because if they can't use it, then it's futile. So what does that look like at TB Alliance specifically? In clinical trials through our community engagement program, we ensure that TB-affected communities, caregivers, patients have a say in how we conduct trials. That the needs of their needs are ultimately what is being designed in our work. In our access initiatives, our civil society engagement has accelerated demand creation. In fact, Robin leads that work at TB Alliance. And what I really want to conclude by saying is we have been successful, but a lot of work needs to be done. And I'm going to put my sort of fundraiser hat right now and sort of point to what Mike has said in terms of the HLM targets that have been set. We are very behind in meeting those targets. So without donor commitments, without commitments from governments, we will not be able to achieve more that I think our promising pipeline shows and points to. Thank you.
So I think those of you who know me know I'm a vaccine person. So I'm very happy to pass it to our third speaker, Alana from IAVI. Go ahead.
Thanks, Mike and Robin, and thank you for bringing us together here as PDPs again. We started this week on Tuesday, actually, before the conference, and it's good to get together and to talk about opportunities and challenges in TB R&D and how we can really move forward and keep the promise alive. So my name is Ilana. I'm a medical director at IAVI, and I'm based in Cape Town, work in the clinical development of the TB vaccines at IAVI. And I'll tell you a little bit of what IAVI is doing in terms of TB vaccine development. We are currently planning for a phase 2B trial with MTB-VAC. And as you know, MTB-VAC is actually one of the most advanced vaccine candidates. It's already in phase 3 trials in infants. And MTB-VAC is really a uniquely promising vaccine candidate. It's a live attenuated vaccine, actually derived from a human sample, so an MTB strain, which means that it actually presents all of the antigens that TB would do. It's just attenuated, so it's not going to make you sick with TB. So as I said, we're preparing for this phase 2B. It's for prevention of disease in adults and adolescents. In IGRA-positive participants who are HIV negative, living in TB endemic areas in sub-Saharan Africa. And as we've heard during the week, and we know that adults and adolescents are really the most underserved population in TB vaccine trials, and really a key population, because if we can prevent disease in adults and adolescents, we can really curb the transmission of TB. And we know from the latest TB report now recently released in 2023, we still have some major gaps in our TB R&D, although we are seeing some recovery from the setbacks due to the COVID pandemic. And I think we do have a lot to learn from the COVID pandemic. But there really is a need for urgent accelerated research and development and employment of new and better TB tools, whether it's drugs or vaccines or diagnostics. And you've highlighted the strong commitments that we've now recently seen at the high-level meeting in terms of TB R&D. And there's definitely a positive energy around vaccine development. I think we're really in a good space, and I think we should leverage that positive energy and really move forward. And the case for a new TB vaccine has never been stronger, both from a business and a public health perspective. The WHO investment case for new TB vaccines demonstrates that the delivery of a 50% effective vaccine for adults and adolescents could, over 25 years, avert 76 million deaths, new cases of TB, and 8.5 million deaths. And that's quite impressive if we can get there. And then also every $1 invested in the development of such a vaccine could generate an economic return of $7 in terms of averted health costs and increased productivity. And just yesterday, I heard this quote. It was in one of the sessions on vaccines and pregnancy. It's by Walter Orenstein from the Emory Vaccine Center. And it says, vaccines does not save lives. And I know that sounds, what? Vaccines does not save lives, but vaccination saves lives. So we have these promising vaccine candidates moving into efficacy trials and already in phase 3 trials. But we really need to start planning now for the implementation and the delivery of these new vaccines. So we need to ensure that there are equitable access to such vaccines, and that we can really control and eventually make TB a thing of the past. But no single country or organization can do this alone. I'm looking at Kristen from the BMGF, the Gates Foundation, and we really need to stop relying on just a few key funders in this space. And I think we really need to create new partnerships at every level of the vaccine development and deployment continuum to make sure that these new vaccines are addressing all populations and geographies, and that these vaccines are actually licensed and available within this decade. And this means that high-burden countries should really contribute their fair share to the benefit of their people that are affected by TB, whether this is by finance, hopefully predominantly, but also by leveraging in-country research capacity and local manufacturing. And I think here I can also add and emphasize what you said. The community engagement is really important for our hobby as well, and we really use the input from the community members in planning our vaccine trials and implementing them. So we really need civil society, communities, researchers to take this message forward that it's time to step up. The countries that are high burden need to come to the party and do their fair share so that we can move forward. And we have the evidence now. We have evidence and political commitments, and we have the energy, and we're moving in the right direction. But it's now time to put this evidence into practice and to really deliver a new licensed TB vaccine in the next 5 years. Thank you.
I like that vaccines don't save lives, vaccinations do. I think we could say the same about drugs. Drugs don't save lives, treatment saves lives. Diagnostics don't save lives, diagnosis saves lives. So that it really emphasizes the importance of access to what we're creating. And that brings me to our fourth panelist, Nandita, who really needs no introduction to those of you in the audience here. One of our best TB advocates and champions, Time 100 Person of the Year, and former speaker at the 2018 high-level meeting. Nandita, I guess I want to ask you to reflect on the role of community, civil society, TB survivors in TB research advocacy, and how far you think we've come since 2018 when you spoke at the high-level meeting to where we are now after the second one.
Thank you. Thanks a lot. So I actually want to start with, so before I came to the union conference here, I was going through my images from the past union conference from 2018, which was held in Amsterdam. And I remember that I had attended and spoke at a session where I think Mike was there and a lot of other people were there, wherein we had at the end of the session, I remember that we had taken like injection cartons and we had thrown it into the dustbin. And I had somehow clicked the image of that and I had saved it. I didn't know that actually that 5 years later that we would actually be seeing one such day here. So it was at that union conference because I just went back before coming for the conference here. I wanted to see what we had done and what has exactly happened. So in the past conference, I know that there was this whole push for better drugs, for example. And this action, I know a lot of us, when we did that back then in 2018 in Hague, when we threw that fake injection carton into the dustbin, there was a huge round of applause, I remember. But exactly, a lot of us, civil society and survivor action has actually meant that a lot of that has translated into real work where we saw that the access to bedaquiline has seen some sort of an improvement because of the work that has been done by a lot of us, including me. So I think I would say that that was a very pivotal moment for many of us, for the fact that we saw that if civil society and survivors and all partners, whether it is governments, whether it is non-profits, everyone come together, there is genuine action that is possible. So I think that in the past couple of years, we have seen that increasingly survivors, driven by their own experience, are coming forward and are trying to become the face of this whole movement. And they are trying to project very strong voices. Previously, we knew that, yes, we knew that there were these nameless, faceless entities who were going through horrible times in their lives. And, it's not, and we knew that there was a disease like TB that is there and that is inflicting large number of populations in many countries. But I would say that definitely in the past 7 to 8 years, I'll say, and I think even the panelists sitting here would agree that in the past decade or something, we are seeing more and more vocal faces coming up, speaking at different panels and trying to own those spaces for themselves, whether it is at universities where we have been called as panelists, including at McGill University, which is where I had met Mikashmi for the first time, whether it is TB Alliance, where I'm aware that there is a community board where I know one of my friends serves on that board as well. And also that does not mean that even though we serve, let's say, on a TB Alliance board, we don't hold back from holding them accountable either. So it happens in both ways, where we feel that yes, that engagement should be there, but it does not prevent us to speak up when we feel that something is amiss. And that is only for the larger benefit of the community, and that is only for the larger benefit of the TB patients. And similarly, I think there has been this huge push now, thankfully, for a TB vaccine. And it is, I think a lot of you would have read the article from ProPublica, which talked about the fact that how an entire vaccine candidate that came into the final stages did not come into fruition. And articles like these really serve as a reminder, I believe, that we cannot rest on our laurels. Yes, there have been big wins that definitely that we should be talking about, we should be cheering about, but we have to build on those and only see to it that we move ahead collectively in terms of making our voices stronger and seeing to it that the UNHLM goals that I had spoken about in 2018 and the ones that were spoken about this time really culminate into something very, very culminate into something very critical by the 2030 targets. So I think that in all of this, I believe that a lot of the survivors have come forward, but now it is important that other people on this panel and other stakeholders also, all of us, get our act together and really move ahead now.
Okay, now we're going to move into the question and answer portion of the session. Mike, I'm thinking that I pose a question and take one from the audience, and our panelists can field 2 questions at a time, and then you pose a question and one from the audience,
Yeah,
so that we
let's
can
do it.
hear from everyone in the room. Great.
So think of your questions and raise your hand if you have one.
Perfect.
Yeah.
I'll start with a question. So I've worked as an advocate for a few years now, and have been a big supporter of PDPs, trying to mobilize resources from Canada for TB Alliance, for FIND, for IAVI, for CEPI, and others, because I want to see a not-for-profit model that was really committed to equitable access for all be the model that is supported by public resources. So that's why I advocate for them. But I have noticed throughout my time of advocating that not all advocates are aware of how PDPs are keeping the promise of equitable access. So I'm wondering if you could give some real-world examples of an equitable access policy, principle, or practice that you could share with the room today. Any questions from the room? Quentin.
Thanks. Hi, everyone. Quentin from the Global Fund Advocates Network. It's for all the panelists. I'd be interested to know, is there any specific tools that you feel where you feel more demand generation would be useful on the ground? Because I feel like we talk quite generically of like, diagnosis, treatment, vaccine. But throughout the conference, I went to a number of sessions that highlighted very specific tools that a bunch of them I had not heard of. And I'd be interested to know if you had a similar experience where you feel like the specific tools that you've heard of this week or that aren't yet on the ground because people don't know about them.
It's on. Okay. Okay, I'll go first. I mean, I'm obviously going to talk about vaccines. I'll address the access question first. And I think access is really at the heart of the IHAVI mission of translating scientific discoveries into affordable, globally accessible public health solutions. And I think access is really part of our whole R&D process. So in terms of what we are doing in the TB space, we are developing or partnering in the development of MTBVAC. And as a vaccine, I already mentioned it's a uniquely promising vaccine, presenting a broad range of antigens, which makes it more immunogenic than BCG that we've seen in the earlier studies that we've done, or that has been done, and also at least as safe as BCG. It doesn't require an adjuvant, so that means that there's no supply price dependence from additional commercial partners. It's a single dose delivery that would support uptake. And we already have manufacturing partners lined up in South America, Europe, and India, increasing the global supply capacity and also supply security and regional equity. We have commitments to an affordable product in terms of this vaccine platform with a relatively low cost of goods, and an established commitment to affordable pricing from commercial partners. And at the same time, I think it's important to prepare for success, and I'll go back to what has also been said before. We really need to create a demand and a desire for a TB vaccine through engaging with communities, where they are, and understanding their context in their country or in the specific regions of their country, as there are differences in country as well in terms of vaccine uptake. And we really cannot do this without the important voices of civil society and community members. And that's why community engagement and advocacy and all of that is very, very important and key to the IHAVI mission. That's in terms of access. I hope I answered the question. And in terms of tools, I think maybe I'll just say in general, and I've touched on it now, that whatever tool you are ready to implement, there needs to be a demand and there needs to be a creation of a desire for this new tool for it to be effective. And I think we can learn from the COVID pandemic and the COVID vaccines, where were these vaccines, but many people just didn't want to take them, or they were not available for the people that needed them the most. So I think it's really just creating that demand and making sure that you can deliver on the promise.
And sorry, go ahead, Anu. I think from the diagnostic side, I definitely see that we need to generate that demand of rapid diagnostics. I mean, that's one of the promises that were made at the UNHLM, that by 2030, 100% of people should be able to get diagnosed with a rapid diagnosis. So that is one. But I think, as you mentioned, there are new sampling methods like tongue swabs, and we are evaluating that at FIND starting 2024. And the reason is for equitable access. There are so many people, kids, people living with HIV, who are unable to produce sputum. So we need to create that demand now, and that is where we really need to have community engagement to understand the reason why we will need to have that equitable access, increase access to testing. And again, as I started off this session by saying, I think we reached that dream of being able to say, I was not diagnosed by a smear microscopy test. So that is where, and that is diagnostic, but also with the upcoming sequencing, we need to have that demand generation. Why is it important to get an upfront diagnostic DST testing done? I need to know my drug resistance profile right when I'm getting tested, so that I know what treatment will work for me. So we need to have that demand generation for both diagnosis of TB, but also drug susceptibility testing.
Could any of the panels or anyone let me know what is being done for extrapulmonary TB? So I think that diagnosis there is still remains a challenge, I believe. Whether it is for intestinal TB, we have brain TB, we have a lot of spinal TB, and each one I think requires a certain kind of focused and different diagnostic methods. So how is the challenge being dealt on that front?
Thank you for asking that question. That is where I started my PhD, so yes. Uh, Extrapulmonary TB is really, really hard to diagnose, and that is where we started off with, again, using, because there is no reference standard, a perfect reference standard that exists, there is no perfect test that exists to diagnose that. So we started off saying, can we use Expert, because that was one of the rapid tests that was available. So we started off by generating that evidence on extrapulmonary TB, starting with TB meningitis, lymph node TB, intestinal TB. And there is evidence that obviously it works much better than just clinically saying that you have TB, or radiologically, or smear microscopy, which just doesn't work. That is one thing of generating evidence on not just Expert, but also all upcoming tests to see that we can diagnose that. And also using the same strategy for generating that evidence using TNGS sequencing, because the drug profiling will matter there as well, and having optimized treatment for people. So I think from what we are trying to do is generate enough evidence that can move the policy in that field, because there are a lot of gaps in extrapulmonary TB for sure.
Thanks for your question, Nandita. I am not a medical doctor, so I will have to take this question back to my colleagues, and I'm happy to follow up with you. But to answer the question on equitable access, I want to take it back actually um, to the R&D phases at TB Alliance. So one example I can give you, which is quite recent, TB Alliance is implementing an NCO09 trial in several countries in Asia and Africa. And unlike trials in the past, we are now attempting to enroll participants that perhaps were left out from trials in the past. So other gender identifying populations and generating data around specifically male, female, and other gender where possible. We understand that there's caveats and exceptions depending on the geographies where we work, but I think thinking about access at very, very early stages and being able to generate data, I think can answer some really important access questions later on how to, equitably treat patients.
The question you asked Nandita and that answer, Anu, makes me think, can you guys reflect on other gaps that you see in the research, things that we haven't looked at enough, populations that we've left out? Extrapulmonary TB is obviously a big one. Collecting data by gender and not just sex is another really important category. We haven't done well in TB. I mean, until recently, we didn't know how to use first-line TB treatment with Depo-Provera. That's how far behind we are in like the TB and women's health agenda. So I'm curious about other gaps that you all see. I'll let you think about that and see if there's a question we can take maybe from the audience. Anybody have a question that you would like to ask? We'll start with the gaps then, while the audience thinks.
Yeah, I was actually thinking as we were talking, and it's not related to extrapulmonary TB, but it's related to subclinical TB. And I think that is something that we really need to start accounting for in our trials and diagnosing that and seeing if our vaccines are also effective against subclinical TB and not just active TB.
And will you define subclinical? Because I have to admit, I don't know what it means. I am so confused about the subclinical concept. I feel like the definition changes every time I talk to somebody. So can you give us the latest?
I'll give you my understanding of it. I feel like a bit like an investigator having to explain this in an informed consent process,
Yeah, perfect.
So subclinical TB are those people who actually have TB disease, but they're not symptomatic. So they'll test positive on hopefully at least on a culture. They might have some X-ray changes, but they won't necessarily know that they are sick with TB because they don't have symptoms or very minimal symptoms that would not prompt them to go to a clinic for testing and diagnosis. If anyone in the audience has a better definition or explanation, then please feel free to share. But I think that's something that we really want to include also in our MTB-VAC trial. And really to make sure that it depends on funding, unfortunately, So that we really make sure that the cases of TB that we see, were they not really already had subclinical TB at the start of the trial, and that our vaccine is effective against that too. That was the one thing, and now I've forgotten the other thing that I wanted to say. Your question was about
Gaps and things we haven't looked at
and
enough.
of course, the inclusion of women and people identifying that can become pregnant. I think including them in our trials as early as possible. I think that's something that we also really need to look into in our vaccine trials as we go forward, and making sure that we are so vulnerable, and maybe just starting by including women who are lactating or women in their later pregnancy, and this will of course depend on the preclinical work that is being done and the data that's available in terms of safety, but really thinking about including them in our.
And can I just add,
Yeah.
kids? We systematically forget them in the program. So pediatric TB, subclinical TB, definitely, thank you for bringing that up. That was on my list because based on the data, about over 50% of the transmission in the community actually happens because people have subclinical TB, and we have no means of diagnosing that. And there is a consortium, and as part of that, it's called the ICE-TB framework. And you're absolutely right, Mike, the definition changes. So that is what we worked on with this consortium, to have one consensus definition of what does it mean. Because if you're not talking about the same thing, we will never be able to do good work in that field. So subclinical TB, pediatric TB, extrapulmonary, we have been missing them, and sex and gender disaggregated data, for sure.
I just wanted to come back to the vaccination during pregnancy or lactating women, or actually even just women who've just delivered babies, because we know the immune system is different when you've just delivered. So it's really about asking the question, are you as a PDP thinking about where on the development pathway between now and implementation of your vaccine, you're going to answer those questions about safety, let alone efficacy, but just safety in women who've just delivered or women in pregnancy, because it's an important group. And there was a speaker earlier in this week where it really struck me when she was saying she was pregnant and diagnosed with TB at the same time, and she just realized she was being left with this decision about what drugs to take, whether to, if there had been a vaccine, whether to get the vaccination. And she's not a scientist, she has no data, but she's been left with this decision. Now, I know the product development answer. You obviously it's always a risk-benefit ratio. Until we have enough safety data, we don't want to be vaccinating. So I'm not at all advocating for taking undue risk. But I'm just wondering if you're thinking about where on that pathway before implementation do you plan to answer that question, so that when we do have rollout, we're not leaving out a group that's really important.
Yeah, thank you. I think ideally we would want to enroll them in a phase 3 trial at the earliest. I mean, when we already have established a safety database for the vaccine and efficacy. But I think, and I was also going to say, the PDP answer of it's always a balance of weighing the risk and the benefit. But with that, if we have enough data and we can present that to the participant and that they are allowed to make a decision, I think that's important. Not deciding on their behalf how much risk they want to expose themselves to. Obviously, we'll guide them and we'll make sure that they are aware of any risks that are there. And I suppose it also depends on the type of vaccine that you are developing. We can look at platforms that have been used for COVID vaccines and try to, if we're using the same type of platform, see what safety data there is in pregnancy in that for the other indication, and see if we can then include these women and people earlier. That was the one thing. But I think we really are sort of as researchers wanting to make the decision before on behalf of people, and I think it's really leaving them to be able to make an informed decision for themselves.
Anu and Nandita, do you all have any other gaps or overlooked areas that you want to call forward?
I think I'll say right now I would really want some more action on extrapulmonary TB. That is one very big area of concern, because I think that cases of extrapulmonary TB have also risen in the past decade or so, but we have seen that a lot of action, or especially on the diagnosis, is lagging behind, especially for things like brain TB. So for, say, an intestinal TB, you do have, at least for now, you do have a conventional CT scan that can help you to some extent. But for something like a brain TB, it still remains a big challenge. So I think brain TB, spinal TB, some of these forms is something, meningitis TB. So I think that I have often seen that some of these forms of TB is where often a lot of delay, at least is what doctors have also told me, is that these forms of TB generally take a lot more time to diagnose, because they are still not sure whether it is TB, whether it is something else. So I think that is one gap, and I would definitely want to see a little bit more action, or if I say something on the vaccine space. So definitely, I think I would say that the ProPublica report was really alarming to me, and I want that at least the panels here, at least the conference here, for the big takeaway is that we really galvanize action on that front, because we are still using a very, very old vaccine right now, and often candidates come into the pipeline and then we don't hear anything about it, and then we only get to know through either news reports or through some activist presentations and things like that. But I think there needs to be more transparency on that front, on what is going on in terms of rolling out a TB vaccine, and also what is being done to collaborate with governments globally to bring it to the populations there. So I think these two would be the ones where I want to see, and I hope to see some more action in the next decade.
Excellent. Anything from you?
I'll just echo what I've heard in terms of the inclusion of pregnant women and persons. I was very excited this week actually to see several sessions on this and presentations around some trials, in fact, that have actually tried doing this. So I've heard more than I ever have. I'm not that new to TB, but it's the first time I've seen so much sort of momentum in this area. So that's very exciting and promising, I think.
So we have to wrap up, I think. Maybe I'll just say a few concluding things that I heard, and then I'll let Robin close. I think you've given us a very nice agenda. Nandita, you said we can't rest on our laurels, although we actually have some laurels we could rest on, and some of us are very tired. And yet, we have extrapulmonary TB to focus on. We have pediatrics, we have pregnant people, we have diverse gender identities, we have a vaccine we need to create to replace BCG or at least complement it, and we need to be more transparent. So that's part of something that we've overlooked, is the transparency around some of this. And I think that is a lot for us to work on over the next 5 years, very aligned with the high-level meeting. Robin.
All right, and so this makes me sick on an almost daily basis, but money, unfortunately, does make the world go round. And the resources in R&D are not there to deliver on the commitments that were just made at the TBHLM. And so we have so much work to do that, because without the resources, we won't be doing the discovery, the development, and the delivery of essential new tools to fight tuberculosis. So I have a kind of ask and a challenge of all of you in the room. I guess my ask and challenge of our PDP partners who are here today is, please do a better job maybe of explaining how you're delivering on the promise, okay? Communicate about that story constantly. Inform advocates on how you're doing it. Give them real world examples of it. So for example, TB Alliance recently supported a volume guarantee for Protomanid, which lowered the cost of it. That's a real world example of a commitment to equitable access and practice, right? Tell those stories and engage with advocates so that they can understand how it's being done. Because if that happens, we're all your champions. We're out there, we're hustling those dollars for you, and we can be a big ally. Look at the Global Fund Advocate Networks. They do a really great job of that for the Global Fund every replenishment cycle. So help us be those advocates and champions for you by telling that story a little bit better and having those conversations so there's some shared understanding. Tell us what the challenges are too, so that we can point fingers and work with donors on some of those challenges to equitable access, because PDPs don't control the market, you know what I mean? They're working with some commercial partners who have for-profit interests. So how can we unblock some of those barriers to equitable access for them as their allies and advocates? Because we can do things and talk about things maybe a little bit differently than PDPs. So that's my ask of PDPs in the room. And then my ask of advocates in the room is educate yourself about PDPs. Lean into their resource mobilization asks and try to get the resources needed to make the not-for-profit product development model the model where public dollars are going and working for people around the world. Okay, that's all. Have a great day.
Thanks, everyone.